After treatment, the scar, the original cancer, and the rest of the skin run on different clocks, so a useful plan must define which problem it is trying to solve. This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon and dermatologist pathologist.
Wait, hold on a second. So the scar I see today isn't the final result? Like, is what I see in the mirror right after surgery exactly what I'm stuck with?
That is the exact question almost every patient has. And the direct answer? No, absolutely not. A fresh surgical scar is biologically active. Right now, collagen is being deposited and degraded, vascularity is changing, and mechanical forces are acting across the wound. The absolute strongest evidence we have on this comes from a multi-center cohort of 990 patients who had facial Mohs surgery. Their patient-reported aesthetic satisfaction and their quality of life outcomes didn't just improve in those early weeks, they continued to improve through at least 1 full year. So the appearance at several weeks is definitely not the appearance at several months, and the appearance at several months is often still not the final result. But as that scar remodels, we really have to watch how it matures. A normally maturing scar gets less vascular and less firm over time. Sometimes, though, it takes a totally different trajectory. You've probably heard of hypertrophic scars and keloids, right? Well, hypertrophic scar is raised and often red, but it stays strictly within the boundaries of the original wound. It kind of stays in its lane. A keloid, on the other hand, extends way beyond those original boundaries and has a much stronger tendency to just persist or even recur. Distinguishing these two is essential. Why? Because their natural history, and frankly what we can expect from treatment, differ wildly based on things like tension, your skin type, and wound depth. And to actually improve a scar, clinicians have to figure out the dominant problem before just throwing a random treatment at it. Like, if the dominant feature is red and vascular, we have to ask, is that vascularity fading naturally, or is there persistent inflammation? If it's raised and firm, is it hypertrophic, or is it just reacting to a buried suture? If it's really wide or depressed, is tension the main culprit? You see, we don't just label a scar bad and move on. We identify the specific phenotype, whether that's texture, pigment, or functional distortion, because that tells us exactly which intervention to use. Okay, but practically speaking, should I just start putting vitamin E on it and massaging the scar immediately to make it look better? Because you hear that advice literally everywhere. You do hear it everywhere, but the clinical evidence tells a very different story. Let's correct the record here. Topical vitamin E is cheap and easy to remember, sure. But in a double-blind, split-scar trial of patients right after skin cancer surgery, it did not improve cosmetic appearance at all. And it gets worse. 33% of the participants actually developed contact dermatitis. That irritation can actually make your scar redder and much more symptomatic. And as for massage, the evidence base there is frequently overstated. Most of the data we have actually comes from highly heterogeneous burn programs, not dermatologic surgery. So while massage might be reasonable for certain closed scars, there isn't one universal start time or technique. It has to be explicitly tailored to your specific repair, like whether you had a flap or a graft, by your treating clinician. So what does the evidence actually support? Well, silicone gel and silicone sheeting have the most portable, low-risk evidence backing them up. A 2020 meta-analysis of randomized trials showed that, compared with doing nothing, topical silicone modestly improved a scar's pigmentation, height, and pliability. It's a modest option, not a magic eraser, but it works. Now, when we evaluate lasers, it's not about universally zapping a fresh scar. Laser treatment has to match the specific target. Pulse dye devices specifically address vascular redness, while fractional devices target remodeling and texture. The data really supports a planned, phenotype-directed series of laser treatments. Just doing one generic early session right at suture removal, there's no evidence that's automatically effective. But here is the absolutely most critical safety boundary when we're talking about the scar clock. A scar does not get a free pass. It is so easy to just assume that any change at an operative site is just scar tissue. Don't do that. A new or progressive nodule, recurrent bleeding, persistent ulceration, progressive pain, or unexplained numbness, all of that deserves immediate clinical assessment. Tumor recurrence, an infection, or even a brand new adjacent primary cancer can clinically overlap with ordinary scar remodeling. We literally cannot assume. We must evaluate. Okay, time for a quick mid-explainer reset. We've been looking really closely at that first clock, the evolving scar. But remember, the original cancer and the rest of the skin are running on their own timelines. So we are now shifting our focus from the scar to the watchtower, which is cancer surveillance, and the shaded path, which is realistic future risk reduction. Wait, so once the scar looks good and is fading nicely, am I completely in the clear? Or do I need routine full body scans forever just to be safe? That right there is exactly why we separate these clocks. A beautifully healed scar does not eliminate the risk of the cancer returning. But on the flip side, getting a scan every 3 months for the rest of your life isn't a universal rule either. Surveillance intensity has to strictly match the diagnosis, the stage, and the tumor risk. For high-risk squamous cell carcinoma or advanced melanoma, follow-up is intensive. It's stage-driven, and time-limited imaging might be part of a coordinated plan. However, for asymptomatic stage IA through IA early-stage melanoma, current NCCN guidance explicitly does not recommend routine imaging. A scan isn't just a generic reassurance test. It's a tool used when the pre-test risk actually justifies it. And keep in mind, surveillance isn't just about watching the old surgical site. For many survivors, the most likely future event is an entirely new primary skin cancer somewhere else on the body. In a prospective cohort of immunocompetent patients, there was a 40.7% 5-year risk of developing another keratinocyte carcinoma after experiencing their first lifetime tumor. And if it wasn't their first tumor, that risk jumped to an astonishing 82%. Melanoma survivors similarly retain a lifelong risk for a second primary tumor. So the watchtower has to look everywhere, not just at the scar. And this watchtower clock can run incredibly long. In randomized, long-term follow-up of facial basal cell carcinoma, more than half of the recurrences appeared beyond the 5-year mark. So a fast-healing scar and a short, clean interval of a year or two are certainly reassuring, but they absolutely do not serve as a permanent exemption from clinical skin surveillance. Because we obviously can't be in the clinic every single day, what happens between scheduled visits is vital. Self-examination provides longitudinal information your clinician simply can't get from a periodic snapshot. But a rigid checklist can sometimes create false reassurance. Instead, we use between-visit escalation rules. You should actively report new lesions, changing spots, recurrent bleeding, non-healing areas, progressive pain, or unexplained numbness. If something is new, changing, or just distinctly different from your other spots, escalate it to your care team. Don't wait around for your next scheduled appointment. Section 3, Layered Prevention and Family Risk. This brings us to the third and final clock, the shaded path. Prevention is not about promising zero risk. It's about layered risk reduction. Step 1, seek shade. Step 2, use protective clothing and broad-brimmed hats. Step 3, apply broad-spectrum, water-resistant SPF 30 or higher on uncovered skin. And Step 4, completely avoid indoor tanning. The NAMBOR randomized trial provided direct evidence that regular sunscreen use significantly reduced the number of squamous cell carcinoma tumors. But notice that sunscreen is Step 3. Clothing often provides much more reliable coverage than a thin, poorly applied, or forgotten layer of sunscreen. The best prevention plan is the set of protections you will actually repeat day after day. Beyond UV protection, patients often ask about chemoprevention pills. Nicotinamide gets brought up a lot, but it is a strictly bounded option. In the OnTrack Phase 3 trial, immunocompetent adults with at least 2 keratinocyte cancers in the prior 5 years saw a 23% reduction in new cancers while taking nicotinamide. But the crucial point is this: there was no evidence of benefit after they stopped taking it. And a separate trial did not show the same chemopreventive benefit in transplant recipients. It is a highly specific tool for selected high-risk adults to discuss with their clinician, absolutely not a universal post-cancer vitamin supplement for everyone. One final real-world question here. Since I had skin cancer, do my kids automatically need to be seen by a dermatologist on my exact same follow-up schedule? You know, it's a great instinct to want to protect your family. But the useful medical message is not, everyone needs my schedule. Your close relatives absolutely should be told about your diagnosis. However, relatives need an individualized risk assessment based on their own phenotype, their ultraviolet history, and their immune status, not just an inherited copy of your surveillance calendar. We look for specific patterns, things like multiple invasive melanomas, or melanoma clustering with pancreatic cancer, or astrocytoma in the family history. Those specific high-risk patterns are what truly justify formal genetic counseling and modified screening schedules for your children. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. Which leaves us with the ultimate question: how will you manage your 3 clocks? The maturing scar, the watchful surveillance of the original cancer, and the layered prevention of the next one all require their own dedicated plan. I encourage you to read the complete evidence-based Skin Trust review for yourself and use this knowledge to have a highly focused, individualized conversation with your treating clinician. Until next time, keep your clocks visible.